Good evening, everyone, and welcome to the webinar, Filling Immunization Gaps, Community Pharmacy's Role. My name is Ruth Ackerman, and I'm the Director of Professional Development at the Ontario Pharmacists Association, and I will be the moderator for this evening. Thank you for joining and taking the time to be here today. So before we get started, I want to talk about this special day. We apologize for doing this webinar on the day of Truth and Recognition, but changing the time was not possible. We set this up a long time ago. So Truth and Reconciliation Week takes place this week from September 27th to October 1st. And it is a time for Canadians to learn more about Indigenous cultural competence, residential schools, and foster awareness on how to build meaningful reconciliation. On September 30th, today, National Day for Truth and Reconciliation will be observed as a national holiday for the first time. Prior to being recognized federally, the date is also Orange Shirt Day, an Indigenous-led initiative that recognizes the history of residential schools while commemorating survivors and those who have been affected. Pharmacy teams are accessible healthcare providers that deliver patient care to a variety of individuals. On National Day for Truth and Reconciliation and throughout the year, we encourage you to set time aside to learn more about Indigenous culture, history, and reconciliation. Deepening your knowledge also provides an opportunity to improve care provided to Indigenous patients and communities. So I realize that we're doing this virtually, but I do want to acknowledge the land where OPA's head office is and where I reside. I acknowledge that the land I am hosting this meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So for those of you who may be new, OPA is Canada's largest advocacy organization and professional development provider for pharmacy professionals across Ontario. With over 10,000 members, OPA is committed to enhancing the pharmacy profession and excellence in patient care. The pharmacy profession has played and continues to play a critical role in the vaccine rollout and battles against COVID-19. We recently celebrated a significant milestone. 4 million COVID-19 vaccine doses have been administered through Ontario's pharmacies. This is a significant feat and demonstrates the integral role of pharmacy professionals in Ontario's healthcare system. Without the support of our members, OPA would not be able to continuously advance the pharmacy profession. Our members make what we do possible. Thank you to all pharmacists, pharmacy technicians, assistants, interns, and students who are working in the front lines and have stepped up to protect our communities and Ontarians. I'd like to thank Pfizer Canada for the support of this webinar. You know, COVID-19 has impacted all of our lives tremendously. And as we continue through this pandemic, we are now seeing impacts in new ways. Access to physicians have been reduced and routine care has taken a backseat to urgent issues. As more of the population is vaccinated, these care gaps are now coming into focus. We will discuss some of these in our webinar. So now to our speaker. As he sets up his presentation, I will tell you a little bit about Dr. Zanel. So he received his PhD in the Department of Medical Microbiology and Infectious Diseases, which are the rock stars of the COVID vaccines, at the Faculty of Medicine, University of Manitoba, and a Doctor of Clinical Pharmacy at the University of Minnesota. He is presently professor in the Department of Medical Microbiology and Infectious Diseases at the College of Medicine and Research Director of the Canadian Antimicrobial Resistance Alliance. Dr. Zanel is the founding and chief editor of the Canadian Antimicrobial Resistance Alliance website. Take it away. In your backyard.
Thank you. Thank you, Ruth. And Ruth, can you see one slide or two?
I see two.
2. Let's change that. I'll just show you one.
And I just realized I didn't tell them about the Q&As. Maybe you could tell them about that, and that they'll get the slides after the presentation. They'll be getting a follow-up email.
Thank you, Ruth. I'll do that. Good evening, everyone. For me, it's a huge pleasure and honor to be with you. Thank you so much for taking the time out of your busy professional life and also your personal life to be with us this evening for about an hour. A few things. Number one, I do apologize, like Ruth did. When we set this up many, many months ago, we didn't know it was going to be Truth and Reconciliation Day. We mean no disrespect to anyone doing CME on this particular and such a most important day, and I hope you don't take it negatively that we did not reschedule. So I'm delighted to be here. I think we primarily have pharmacists and pharmacy technicians in Ontario, but if you are tuning in from other provinces, welcome. And thank you so much for being with us. Some housekeeping. If you have questions and comments, and please, I want you to. I don't want to hear just snoring on the other side. I want you to enjoy yourself and be engaged. If you have questions or comments, put them into the chat box. Chat it out. Ruth will be the boss of the questions, and she will ask your question. So that way, for those of you who don't want to ask it personally, she will ask your questions for you. Secondly, after the presentation is over, you will get an email from OPA. You'll get a copy of the presentation as well as the video. So you will get the slides. I don't want you taking a lot of notes. I want you sitting back, enjoying yourself, thinking about a comment or a question, and having a little bit of fun. The most important thing today that I'm doing is saying thank you to all of you. You guys are the big heroes. You're the ones vaccinating and preventing morbidity and mortality, whether you're administering the regular flu shot, high-dose flu, pneumococcal vaccines such as Pneumovax, Prevnar 13, all the COVID vaccines that you've given. Thank you, thank you, thank you for what you are doing. And I'm here basically to say, please keep on going. Let's not forget all of the different vaccinations. We can't just focus on COVID. So I've talked about the slides and the questions. Oh, what I do have to tell you is that I'm one of these guys that stands in his office. And when I stand, I at times move around. And when I teach pharmacy students, medical students, nursing students, etc., on occasion, someone says, I wish he'd just stand in one spot. So I apologize in advance. I move around at times just to get some blood flowing in the legs. Okay, so let's get started and have a little bit of fun. This is my official title, Filling Immunization Gaps, Community Pharmacy's Role. Many of you know me because I used to travel across the country and speak to a whole bunch of different groups, especially community and hospital pharmacists. So I think many of you know me. For me, it's a real pleasure to be with you today. I'm going to do a little intro, give you my disclosures, and then go right to the objectives. One of my 4 jobs is I'm the research chair of a group called CARA, Canadian Antimicrobial Resistance Alliance. In the olden days, when you used to fly on planes, we brought you food and made you supper. Now we no longer do that because you don't fly. What are we? We're a research organization. We're interested in infections caused by antibiotic resistant strains in Canada, coast to coast, outpatients, inpatients. And I've yellowed out treatment and prevention. We study every single antibiotic in your practice and every antibiotic that will be in your practice over the next 5 years. And we study vaccines, including the vaccines we're going to talk about today. We have a website, www.canforcanada-r.com. And my disclosures, I want you to know that I get research funding from a whole variety of companies that make antibiotics and also vaccines, including Pfizer. I also want you to know that I'm receiving both a speaker's fee and a huge hug from Ruth, both from the Ontario Pharmacists Association. I think the hug is going to be virtual, even though we're both vaccinated. Lastly, I acknowledge that this educational event has received financial support from Pfizer. And I also have 2 big thank yous for some of these slides, especially the COVID slides. I have a couple of people who really patrol the internet and helped me to make sure that I got the most current information to you. I'm very thankful to Dr. Rajiv Nepal and Dr. Gary Lam for helping me put some of the COVID slides together. So I teach a lot of students, pharmacy students, medicine, nursing, science students, laboratory techs. This is my favorite slide. This slide gives a huge pitch for infectious diseases. This slide looks at life expectancy. Humans like us, anatomically correct humans, we've been around for about 400,000 years. And I want you to see that life expectancy was somewhere around 30, 35 years of age. Typically, it was some sort of traumatic event, a mammoth stabbed you or something happened and you died. And then what happened in the 1800s? We started to develop vaccines. Then we started to realize that hygiene was important. We started to treat our water. We started refrigeration. We started to clean take care of our poop and our pee. And then we also discovered antibiotics. And all of a sudden now, life expectancy has tripled, if not more, over the last 200 years. Why? Vaccines, antibiotics, and hygiene. My focus tonight is vaccines. I'll show you one general vaccine slide, and I just want you to look at the yellow. The yellow shows the dramatic reductions that have occurred with smallpox, diphtheria, pertussis, tetanus, polio, right down to the bottom. I started off in pharmacy and did a PharmD University of Minnesota, and I'm old enough that when I was in the Mayo Clinic in Minnesota, in northern Minnesota, we had patients coming in with Haemophilus influenza, meningitis, and adults with epiglottitis, and they would literally have an obstruction of their airway. And when Haemophilus influenza vaccine came out, it was life-saving. Vaccines are an enormous way to prevent morbidity and mortality. So what am I going to focus on this evening? I'm going to focus on the three arrows. I'm going to focus on respiratory pathogens, two viruses. I'm going to talk about for 5 minutes about the influenza, the flu virus. I'll talk a little bit about the COVID-19 virus, SARS-CoV-2, mostly to say thank you to you and show you some most current numbers, some successes, but challenges we still have. And I'll spend about 20 minutes talking about the most important bacteria causing respiratory illness, Streptococcus pneumonia, and I'll call that the pneumococcus. It's the same thing. So a little bit of flu, some COVID, and some pneumococcus. Why am I lumping these pathogens together? Because respiratory pathogens like flu, SARS-CoV-2, and strep pneumo, they're contagious. You transmit them through droplets. We cough, we sneeze, we talk, we sing, we spray our droplets onto people. These droplets have the virus. The virus lands on our respiratory epithelium, and then it starts to initiate colonization and potentially infection. So you've heard a lot these days over the last year and a half about a group called NIESR. NIESR before was obscure, no one knew about it. It stands for the National, in Canada, Association for Immunization. And what I want you to know about it is this is the Canadian group that basically sends out policy, volunteer group, sends out policy of what we should be doing. What do they say? They say during COVID-19 pandemic, please do not forget about your other vaccines. Do not forget about the flu. Do not forget about the pneumococcus. They're very quick to say, please don't forget about the other vaccines. Ruth made a very important point. Many of your patients, as you don't neglect it. They're not coming in to see you as often. They're not coming into the doctor's office. They're not coming in for care. They're scared. There's a pandemic going on, 1-way, 2-way, 3-way, 4-way. Many are missing vaccinations. We need to get these vaccinations up. So here's what I'm going to do. Number one, I'm going to spend 5 minutes talking about influenza vaccination. Then I'll spend 20 minutes talking about pneumococcal vaccination. Then we're going to stretch. For those of you who are sleeping, I just ask you to put it on mute. Then we stretch, you wake up, you perk up. I'll do 15 minutes of COVID, mostly to say thank you and show you our successes and our challenges. And then I'll spend the last few minutes talking about hesitancy. We've got some interesting new strategies from Ontario. I want to share that with you. And I also should be telling you, and I should have told you at the beginning, Ruth and I put some polling questions together. So when a polling question comes, I'm going to read it. Ruth is trying out her new technology. Fingers crossed it's going to work. But the goal is we engage and we have a little bit of fun together. And I'll give you some during the flu, the pneumococcus, vaccine, COVID vaccines. We'll do them throughout to keep you engaged. Let's start with the flu, only for 5 minutes. Influenza, the flu, is the most important respiratory virus up until COVID came. Now COVID is number one, the flu is number two. NIESR says, don't forget about the flu. Here's our polling question. I'm going to read it. Then Ruth is going to activate it. We'll see if it works. All of you, will you recommend and administer a flu shot to as many patients as possible once the vaccines are available this fall of 2021? Yes is one, no is no. Please put in your answers. Normally, we'd have some background music, maybe some Elvis or Elton John, and I could be doing some dancing, but Ruth has not provided music.
No. Okay, well, they're answering it, and this is fantastic. And guess what? 100%.
Wow. I love you guys. Thank you so much for doing this. I'm speaking to the choir over here. Thank you for that, Ruth. Thank you for those of you who responded. 100%. I'm talking to my people. Thank you for that. Let me keep going. I'm going to click out. Here's what I want you to remember about the flu. You're giving the flu shot for 3 reasons. Number one, to protect your patients. When you give the flu shot, you reduce influenza illness, which means your patients are less likely to get infection. They're less likely to go to an outpatient clinic, to the emerge, urgent care. They're less likely to be hospitalized, less likely to die. That helps them. 2, when you immunize your patients with the flu shot, they now no longer carry the flu virus in their spit and snot, so they can't spray it onto others. What does that mean? You are helping them protect their family and their friends and their community. Lastly, what I like about the flu shot is giving the flu shot is an antimicrobial stewardship strategy. Why? You give the flu shot, you have less respiratory illness, less outpatient use of amoxicillin, azithromycin, doxycycline, levofloxacin. What does that mean? Less destruction of the normal bacteria flora in the mouth and oral cavity, in the colon, the vagina, and the skin, less antibiotic resistance. Giving the flu shot is an antimicrobial stewardship strategy, and that's a world benefit because these resistant pathogens spread around the world. Thank you for giving the flu shot. This is why you're giving it for 3 reasons. What do I want you to do? I think in Ontario, Ruth, pharmacists can only administer the flu shot to patients 2 years of age and older, I believe. The NIESR guidelines and the Centers for Disease Control, they say, look, we want you to give it to everyone 6 months of age and older. And then in your jurisdiction, you just apply your laws and give it to everyone who's 2 years of age and older. And I mean everyone. Ideally, you would consider your staff, patients coming into your pharmacy or to your clinic, any kind of visitors. The more people we get immunized, the less we're spreading the flu virus onto everybody else. What's the stuff that's hot off the press? HighDose Flu. And I have great news for you in Ontario. This was a really great study. This was a study comparing the HighDose flu shot. This was trivalent in those days, against the regular flu shot, which was also trivalent in those days. 2.5 million people. Half got regular flu shot, half got HighDose flu. And they studied these patients who were all 65 years of age and older, 2.5 million of them. And what they showed is the HighDose flu shot was better than the regular shot, 22% less illness, but look where the arrow is, 22% less emergency visits and hospitalizations. And that's why all the governments have bought on, because it's cost effective. You can reduce emergency visits, reduce people going to the hospital. Then the researchers followed up to show a reduction in mortality. They saved lives by 36%. What has happened in Canada and in the US, this has now become the standard of care. So this is my last flu slide. What I'd like you to consider doing this fall is I want you to consider and offer the HighDose flu to any of your patients who are 65 years of age and older. This year, it'll be the quadrivalent that'll be available in Ontario and across Canada. Most of the regular shots are going to be quadrivalent this fall as well. NIESR says it's superior. and we should do it. And the great news is in Ontario, it's free. If you're 65 years of age and older, the government pays. So now in 5 provinces, the government pays if you're 65. In some places like Manitoba, if you're in a long-term care facility at 65, we pay. But now it's the standard of care. It's free. Please give the regular shot to as many people as you can. HighDose Flu for those over 65. Let me jump over to a bacteria. Please save your comments and questions on the flu to the end. What about the pneumococcus? Let's spend a few minutes talking about the most important bacterial cause of respiratory illness. Here's the pneumococcus. I'll use these terms interchangeably. This is the most important bacteria causing respiratory illness. A refresher, the pneumococcus is the #1 cause of CAP, which is community-acquired pneumonia. #1 cause of acute bacterial sinusitis, #1 cause of middle ear infection, #2 cause of acute exacerbations of COPD. And if it gets into the blood, it causes what we call invasive pneumococcal disease, IPD. What does that mean? It got into the blood or into the brain, and it can cause sepsis. This is a bad bug, and we can prevent it now with vaccinations. Here I'm showing you some data from Europe, same data in Canada. I want you to look at the 2 arrows. What causes community-acquired pneumonia? About 1/3 of it on the left is the pneumococcus. We can prevent this with vaccines, and that's what we're going to talk about now. On the right, these are viruses. A lot of these are influenza viruses. These days, COVID-19. We can prevent that with vaccination as well. What about Canadian data? This is Canadian data on hospitalization due to pneumococcal pneumonia. Look at the 2 arrows on the left, the little kids. That's why every kid in Canada gets Prevnar 13. Why? We want to prevent pneumococcal illness, invasive disease in children and pneumonia. But then look at the arrow on the right. As we get older, over the age of 65, there's a big skyrocketing of pneumococcal pneumonia. We immunize all the kids. Today, I'm going to be talking about immunizing the adults. And I'll have a very clear theme that there are 3 groups. I want you to give both Prevnar 13 to, followed by Pneumovax 8 weeks later. And this is a big theme, and I'll repeat this theme many times over the next 10 minutes. I want you to know that 2 things are associated with risk for pneumococcal pneumonia. One is age. As you get older, you're more likely to get pneumococcal pneumonia, so age is going to be a big risk factor. And today, I want you to remember, everybody in your practice, when they turn 65, ideally gets both Prevnar 13, anytime 8 weeks later, Pneumovax. And I'll talk a lot more about that over the next few minutes. But then I also want you to see that if you have medical problems, chronic lung disease, asthma, neuromuscular, alcoholism, liver disease, rheumatoid, Crohn's, lupus, smokers, heart disease, diabetes, you're on steroids, you're at an increased risk for pneumococcal disease. So another group that I'm going to be talking about today will be the immunocompromised. And anyone of any age, if they're immunocompromised, I'm going to ask you to give them both Prevnar 13 and Pneumovax. And lastly, I'm going to focus on older individuals, older than 50 years of age, who have these medical problems. We have Canadian data I'll show you that says we should give them both Prevnar and then Pneumovax. In fact, let's go to this Canadian data hot off the press. So a colleague of mine, Dr. Jason LeBlanc, with colleagues, published a paper last year, and they looked at Canadians who were hospitalized for pneumococcal pneumonia. And the focus was age as a risk factor. And let me show you what they found. This is a busy slide, and I apologize. I want you to see the title. They looked at Canadians who were 50 years of age and older and had a medical problem. Lung disease, liver disease, renal disease, etc. And they looked if they were hospitalized, what they were hospitalized with, and a lot of these individuals had pneumococcal pneumonia that could have been prevented with vaccination. And if you look at the yellow, if you are not vaccinated and you develop pneumococcal pneumonia, 30% of these patients made it to the ICU. 10% died, and 20% needed ventilatory support. So from this paper have built strong recommendations that if we have Canadians who are 50 years of age and older with a medical problem, lung disease, heart disease, liver disease, kidney disease, etc., we should give them both Prevnar 13 followed by Pneumovax to minimize this morbidity and mortality. So let me quickly summarize this. Then I'm going to explain the vaccines briefly, and then we'll do some fun cases. I want you to take home today the pneumococcal infection is associated with lots of morbidity and mortality. We just talked about that. And now what I'm going to do is I'm going to focus on my three groups. I'm going to try and convince you today using cases that there are three groups that I would like you to give both Prevnar 13 followed by Pneumovax. One is an immunocompromised patient of any age, and I'll do a case. Two is anyone over 50 years of age with a medical problem, and I'll do one of those cases. And then anyone over 65 years of age, whether they're healthy or not healthy, should get both of these vaccines. And what I'm going to do is I'm going to spend 2 minutes talking about Pneumovax, 2 minutes talking about Prevnar, and then I'm going to use cases to ingrain this knowledge and trying to convince you that these are the three groups I want you to immunize. So we have two vaccines. We have a Pneumovax, PPSV23, and we have Prevnar 13. Let me, for 2 minutes, explain Pneumovax, its advantages and disadvantages, and why I want you to use it. And then let me explain Prevnar 13 for a couple of minutes and explain to you why I would like you to use it as well. In fact, why I'd like you to use both of them. So these are the NIESR recommendations in Canada for who to give Pneumovax to. And you see it's a huge list. To take you through it, go to the very right. NIESR says anyone 65 years of age and older, we should give them Pneumovax. Then on the far left, NIESR says if you're over 2 years of age, under 2, as you know, you get Prevnar, but if you're over 2 years of age and you're immunocompetent, but you have disease, heart, lung, diabetes, liver, CSF leak, cochlear implant, neurological problems, asthma, you should get Pneumovax. NIESR says if you're in the middle, if you're immunocompromised, due to any reason, functional or anatomic asplenia, sickle cell, HIV, immune deficiencies, immune suppression, including due to drugs, steroids, a lot of these biologics, you got a stem cell transplant, solid organ islet cell transplant, any malignancy or chronic renal disease, you need Pneumovax. And then they say if you're over 18, but you're in a long-term care setting, you're homeless on the street, you're an alcoholic, smoker, illicit drug use, asthma, you should get Pneumovax. So this is a big list. Why does NIESR say to use this? There are some advantages with this vaccine. Let me briefly review them. Pneumovax has some advantages. Number one, it's old, and we know it's safe. So the safety is proven. The other advantage is 23, it covers 23 different pneumococcal capsules, meaning it's broad spectrum. And I'll show you data. I want you to remember that it's pretty good for preventing invasive pneumococcal disease. It's good. It's about 50% effective. And I want you to remember that. The disadvantage is this is old. This came out in the 60s. It came out when we were doing polysaccharide, which are sugar vaccines that elicit only a B-cell immune response. So this is old technology. The downside with the old technology is we get poor response in older people, immunocompromised in little kids. That's why we give the kids Prevnar. We have no memory. We don't boost. We, in fact, get hypo-responsiveness now if we revaccinate. We don't get herd immunity, and it's not a pneumonia shot. A lot of people call this a pneumonia shot. It's a blood shot. It prevents blood infection. It does not prevent pneumonia. I'll show you that on the next slide. How good is Pneumovax at preventing invasive disease? Good. It's 50%, and I want you to remember that because I'm going to show you 2 minutes from now how Prevnar is about 75% versus 50. Why? It's better technology. How good is it preventing pneumonia? It sucks. It's poor. It's about 10%. I'll show you data that Prevnar is close to 50%. So I want you to remember, Pneumovax is not the pneumonia shot. That's what we called it years ago. But now we know it doesn't prevent pneumonia. It's the blood shot. That's Pneumovax. Let's talk about Prevnar 13 for adults. The Health Canada indication is if you're 18 years of age and older to prevent pneumonia and invasive disease. NIESR says we want you to consider 3 groups. They are very strong, NIESR, on immunocompromised. They say if you're immunocompromised of any age, please give both Prevnar 13 and Pneumovax. For Prevnar 13, NIESR says if you're 65 years of age and older, consider and recommend to your patients individually to get Prevnar. And please also give them Pneumovax. Currently, NIESR is silent on if you're 50 or older with comorbidities. Why? The LeBlanc data is hot off the press. They still don't have a recommendation that we should give both Prevnar and Pneumovax to patients 50 and older with comorbidities. That is something that I'm asking you to do because the benefit dramatically outweighs any risk. So let's for 2 minutes talk about Prevnar 13. This is new technology. And what I mean by that is we call this a conjugated vaccine. Conjugated, remember in pharmacy school, means join or ligate. You're joining a protein and a sugar together. You're conjugating them, and so you get a B cell and a T cell response. What does that mean? This is both a blood and a pneumonia shot, and I'll show you the data. It's very safe. It gives a very good immune response in the very old, immunocompromised, and in kids. This is why we give it to kids. It gives you memory, you boost, and the best thing about it that I like is herd immunity. You give Prevnar 13, you wipe out the pneumococci if you're carrying them in your snot and spit in your nasopharynx, so you don't spit it, spray it onto someone else. That's a huge positive. Disadvantage, it only has 13 serotypes. It's narrow spectrum. If I had the technology today and we could do a Prevnar 23, I would never talk about Pneumovax again. And we will have that one day, but it's going to take time. So right now, up until we get that technology, we're asking you to do both. Prevnar 13 first. Once you get an immune response, which is 8 weeks later, then you give Pneumovax. Couple of final slides, and then I'm going to go on to cases. Here's Prevnar 13 efficacy. I want you to look at the arrows. This is the famous CAPITA study published in New England Journal. 75% reduction in invasive disease. Remember, Pneumovax was 50%. The second arrow, 45% reduction in pneumonia. Remember, Pneumovax was 10%. This is a superior vaccine because we have the new conjugated technology. The other thing I want you to see before we do cases is that both the blood shot, Pneumovax, and the blood protection of Prevnar 13 protect bacterium and meningitis. But the vast majority of the disease that is out there from the pneumococcus is in the lungs, not in the blood. Only Prevnar 13 is the pneumonia shot. So Prevnar 13 is the pneumonia shot and the blood shot. Remember, Pneumovax is only the blood shot. Okay, that's the theory. Hopefully you haven't fallen asleep. Here we go with cases and then some polling questions. Now let's review who and how I want you to immunize patients with both Prevnar 13 and Pneumovax. I'm going to do one of each. I'll do a case of an adult who's immunocompromised. Then I'll do a case of a patient who's 65 years of age, with and without any medical problems. And then I'll do a case of someone over 50 years of age with a medical problem, and I'll talk about what I would like you to give them this fall. Let's start with Carol. Carol's 55. And by the way, in your questions and comments, you may ask me, what if Carol's 30, 40, what would you do then? And I'm happy to answer that. But in this case, Carol's 55. Carol is immunocompromised. She's healthy, she's very active, but she has severe plaque psoriasis and she's one of these anti-TNF agents. She's never received pneumococcal vaccination. What would I like you to do with her this fall? I want you to give her the flu shot. I want you to make sure she's had her COVID vaccinations, both of them. These days, we don't talk about one shot. I wish we'd stop talking about one COVID shot. You're either fully or you're not protected from the Delta variant. Carol needs the flu shot, ideally quadrivalent. She needs both of her COVID shots. On the pneumococcal side, she needs both Prevnar 13, and then she needs Pneumovax. So let's put this into operation. This is my worst slide, I promise. This is NIESR saying, here's what I want you to do if someone is immunocompromised. If you're immunocompromised with any of these conditions on the left side, stem cell transplant, HIV, asplenia, sickle cell, immunodeficiencies, immunosuppressive therapy, and malignancy, transplant. So Carol's under immunosuppressive, meaning if you're on steroids, chemo, radiation, etc., you are immunocompromised. What does NIESR say? Carol, at the age of 55, should get Prevnar today. And ideally, you would give her the flu shot in the other arm on the same visit. Then you wait minimally 8 weeks. After 8 weeks, Carol gets a wonderful immunological response. Anytime after that, you give her Pneumovax. Then NIESR says 5 years later, when Carol turns 60, you give her Pneumovax. So I want you to remember this. This is NIESR saying you always give the conjugated first. You could give Carol the flu shot in one arm, Prevnar 13 in the other arm, anytime after 8 weeks. Then you can give her Pneumovax. 5 years later, she turns 60, you give her Pneumovax. I'm delighted in the question and answer if you vary Carol when she's 30 or 40, and let's redo it and have some fun. Case number 2. This is Florence. She's my patient who represents someone who's 65 or turned 65, or in this case, Florence, you don't know if she's ever had pneumococcal vaccine. She's 80. She's increasingly frail. She used to walk a lot. Now she walks a heck of a whole lot less. She more likes to cook and read and see her family. She doesn't know if she's had the pneumococcal vaccination. What do you do with her? Ideally, you start off by giving her a HighDose Flu in this arm, HighDose Influenza. You make sure she's received her COVID shots. Then you give her Prevnar 13 in this arm, and then you say, Florence, I want you to come back 8 weeks later, and then you give her Pneumovax, and then she's done. You can vary Florence and make her older, and we can chat it up in terms of what to do with Florence 5, 10, 15 years later. One thing I want you to remember, before you give Prevnar to an adult, you ask them one question: have you received Pneumovax previously? And if they say no, great. You give Prevnar 13, you wait the 8 weeks, you give the Pneumovax. If a patient says, yes, I have received the Pneumovax, then you say when? And if it's been at least a year, good. You give them the Prevnar 13. If it hasn't been a year, you wait up until a year has gone by since they've had Pneumovax, then you give Prevnar 13. Why? Because if you don't wait long enough after the Pneumovax, the immune response from the Prevnar 13 is blunted. It doesn't go as high as it should. That's hypo-responsiveness. So please remember to ask this question. Before you give Prevnar 13, have you been vaccinated with Pneumovax? The answer is no. Great. Prevnar 13. My last case is Doug. Doug is over 50 years of age. In fact, he's 58. So he represents a 50 and over year old male who has medical problems. In this case, Doug is a big smoker. He has bad lungs. He gets tweaked with some oral prednisone now and then. What do you do with him? He needs a flu shot. You got to give him the flu shot in this arm, Prevnar 13 in the other arm. Doug, I want you to come back 8 weeks later. You give him Pneumovax. And you also really have to make sure he's at his COVID shots. Why? He's at a huge risk, as you know, for respiratory infection due to viruses and bacteria. So let me wrap this up and we'll do a quick stretch. Who are you going to give the flu shot to? For you, everyone 2 years of age and older. HighDose Flu if they're 65. Prevnar 13 Pneumovax, the big three. I want you to focus on 50 and over with medical problems, immunocompromised of any age, or over 65. And ideally, you give them both. Prevnar 13 first, you wait minimally 8 weeks, then Pneumovax. What about payment in Ontario? Well, here's what NIESR says. NIESR says for influenza, we really want you to give it to everyone. And in Ontario, it's paid for everyone, including HighDose Flu if you're over 65. Pneumococcus. NIESR says don't give it to the kids. It doesn't work because it's old technology. But for the other three groups, give it. It works and we'll pay for it. NIESR, what do they say with Prevnar 13? Give it to the little kids and we pay. Give it to adults who are immunocompromised and we pay. Please consider and recommend it individually to patients 65 years of age. Right now, we're still not paying, so you got to pay that out of pocket. And for adults with comorbidity, they have not yet reviewed the LeBlanc data, so they do not have a recommendation there. This is me asking you to consider in patients 50 and older with comorbidity, ask and ideally recommend they get both Prevnar 13 and Pneumococcus. You will reduce morbidity and especially mortality. Ruth, time for another polling question. Let's see if anyone's awake. Number 2, would you recommend and administer Pneumococcus, the blood shot, in the fall of 2021? Would you consider recommending administering it to patients with comorbid conditions, with immunocompromised conditions, and in patients greater than or equal to 65 years of age? Ideally, you'd give it with Prevnar 13. Would you consider that, yes or no? Oh, and Ruth, you're being high tech. You've turned into 3 separate questions. So hopefully our listeners will know how to do that.
They're doing it. We're seeing results.
Thank you all for participating in this. What are they saying, Ruth?
Well, they're pretty good. They've been paying attention. They didn't fall asleep. I can tell you that much.
Fantastic.
So we've got 93% are going to give it to adults with morbid conditions.
Yes.
87% adults with immunocompromised conditions.
Excellent.
And 93% adults greater than or equal to 65 years of age.
Really great news. Thank you for that. Thank you all for responding to this particular poll. We'll take that polling question down. Let's go to polling question number 3. Let's now talk about Prevnar. Would you recommend and administer Prevnar 13 to the same group, over 50 with comorbid conditions, immunocompromised, or greater or equal to 65, ideally with Pneumococcus, as you know? Let us know what you think. And that'll be the end of the pneumococcal vaccine section.
So they're still awake. Looking good. So
thank you so much for your participation. What do they think, Ruth?
Almost 100% agree with both individuals with comorbid conditions and immunocompromising conditions. And they're not as 100%, but they're at 94% for the individuals greater than or equal to 65.
Thank you so much for considering this. As you know, you're the heroes, the champions, the lifesavers out there. Thank you for doing what you're doing. So folks, at this point, what I want you to do, if you're sitting down, I want you to stretch. If you're on the couch, I want you to stretch. If you're like me, standing up, move your legs around, get some blood flow. I'm going to spend 10 minutes on COVID vaccines, 2 on hesitancy, and then we'll do questions. I promise. This next part really is just to say thank you. So let's jump in and do some COVID stuff. And my real goal here is to say thank you for what you're doing, to show you some numbers of where we are. But first, another polling question. Have you yourself received the COVID-19 vaccine, Pfizer, Moderna, or AstraZeneca? Yes or no?
So we have the 2 of them at the same time. I apologize. Your second one is up too. So
the second question is, have you recommended and are you recommending that your patients get a COVID-19 vaccine? Ruth, you clearly have a hot date. You want to push the questions out quickly to get it done.
yes.
Good for you.
That's right.
What are they saying, Ruth?
Oh man. Okay. So have you had your COVID-19 vaccination? 100%. And are you recommending 94%?
Terrific. Terrific. Thank you for that. Let's take that down and jump ahead. Polling question number 5. Oh, no, that was Ruth.
Oh, no, we already did that.
So I took some data hot off the press here. So this is as of 3 days ago. This is Canada. So you remember wave 1 was in kind of March, April, May. Then Canada had a good summer. Then in December, January was a disaster. Then things got better. Then April, May was a disaster. Then things got better. And now September again, we've got some issues. Well, let's look at provincially. So I took this off the press a couple of days ago. In the past 7 days, Canada, that's the arrow in the top, we had 30,000 cases over a 7-day period. Ontario, around 4,000. You see Quebec, 4.5. Look at Alberta. It's a disaster, 11,000 with our friends in Alberta. BC over 5, Saskatchewan over 3,000. And then some other places, Manitoba, 500. We've got some issues in New Brunswick, 500. We've got a lot of COVID still. Here's some good news. I pulled this off the press 2 days ago. The dark green is fully vaccinated. And I'm only interested in fully because fully means you protect against Delta. So here's Canada, 71%, China, France, the UK, Japan, Israel, Germany, the US, Australia, Mexico, India. I put a bunch of countries I thought you'd be interested in. We've been a big success story, but we need to get higher, as you know. We need to get our teenagers done, 12 to 17. It'll come out to the younger kids shortly, but we have about 20% of the population who just doesn't want to get vaccinated. And as you know, they're the ones who are filling up all the ICUs in Ontario, Alberta, and across the country. It really is an epidemic of sick people with sick illness of the unvaccinated. How are we doing vaccinating provincially? Canada, close to 70%. Ontario is around 70%. You see Quebec, the Maritimes a little higher, BC a little higher, but you see the problems. Look at Alberta, look at Saskatchewan, not great, and that's why they have a lot of illness. So we need to get this a little higher very quickly, and you know all this, so I'm not going to review this. In Canada, the vast majority of you and your patients got Pfizer or Moderna. Many of you got AstraZeneca as well as your patients. There are many other vaccines that will come out soon. The big thing that has changed is this. NIESR consistently keeps upgrading their recommendations as more data is coming out. Now we have tremendous data in kids, patients with chronic conditions, anyone who's immunosuppressed due to any reason, anyone due to autoimmune condition, pregnancy in any trimester, and breastfeeding, adolescents. We have enormous data that the vaccine is safe and it works in all these groups. And NIESR says, please recommend it. And then Ruth and I talked about this a couple days ago. NIESR came out with a 140-page document that I'm going to distill for you into one slide. And they basically updated their recommendations. And here's the 4 most important things I thought were relevant for us tonight. Number 1, NIESR said the Moderna, which is now called Spikevax in Canada, and Pfizer-BioNTech, which is called Comirnaty, now they're officially indicated for teenagers, 12 to 17 in Canada. And we're trying to get them all vaccinated. Why? Teenagers acquire and spread the virus like crazy. They can get sick. They're not as likely to get sick, but they're great spreaders. And they're really good at acquiring the virus. 2, NIESR says that we should boost people who are immunocompromised. And there's a lot of variability. What does immunocompromised mean? Why are you immunocompromised? How immunocompromised? But as a general matter, giving them a booster, especially if you're 6 months out, is a good idea. So if you got a vaccine in April, you're getting to your 6-month lag phase. We know with Pfizer, once you're around 6 months, you start to wane. 3, NIESR says we should also boost for Canadians who live in long-term care facilities, assisted living, any kind of congregate settings. We should boost them. Lastly, and this is an important one because this has changed. NIESR says, you know what? We used to say only give the COVID-19 vaccine alone. Now they're saying that you can give another vaccine at the same time, before or after. And that includes a flu shot. And that includes Prevnar. And that includes Pneumococcus. This is new. When I got the vaccine, when you got the vaccine, they were very clear. I don't want you to have had anything 2 weeks before, and I don't want you to get anything 4 weeks after, till 4 weeks after. Now they're saying, you know what? You could stick COVID in this shoulder, the flu shot here, and you're golden. I want you to remember this. This is important. Just came out 2 days ago. But we still have unresolved questions. And I want to discuss this in the question and answer. When's the best time to give boosters? Is it after you've been at least 4 months out, 6 months out, 8 months out of your shot? And who do we give it to? Right now, it's just congregate living centers and immunocompromised. Other places like Israel and the US, they're greatly expanding the booster program. What should we do? Should we mix them? Is it a good idea if you before had 2 Pfizers, that now we boost you with the Moderna? Or if you've only had 1 dose of Moderna, should we give you a Pfizer? There's data coming out that mixing is actually a good thing from an immunological perspective, because the immune system sees an antigen coming at it a different way. Can we co-administer the flu shot with COVID or pneumonia shot? Yes, we can. Now we know the answer is yes. Will the variants result in vaccine-resistant COVID-19? We're worried about these variants. Variants are essentially the wild-type virus with mutations. And I'll talk about the variants 2 minutes from now, because I think they will continue to be a huge problem. And I worry in the future that we'll have less and less and less vaccine effectiveness with the variants. Since we have several vaccines, should you be able to choose? If you've only had 1 shot, can you say, well, I want Moderna. Well, I want Pfizer. Will the vaccines prevent asymptomatic infection? I want you to remember the vaccines were not designed to prevent asymptomatic transmission, nor were they designed for you not to catch the infection. They were designed so if you got it, you didn't get on a ventilator, you didn't get hospitalized, you didn't die. But we do know the vaccines are actually very good at preventing infection, and they're very good at preventing asymptomatic carriage and transmission. That's the big news. Should vaccine COVID-19 actually be mandatory? As you know, this is a huge political thing all around the world. What do we do with individuals who do not want to get the vaccines? Well, it seems like we put them on television every night. They picket in front of pharmacies, hospitals, and we just give them all this airtime. What do we do with kids? We're going to be vaccinating kids like crazy, the 12 to 17. And I think in Canada shortly, you're going to see some really good data, and NIESR will approve minimally Pfizer and then Moderna for kids 5 to 11, and then likely younger and younger till 6 months of age. That data is coming, and so far it looks very safe and very effective. How long will immunity last? We have good data from Israel, from Pfizer, about 6 months. Once you get to around 6 months, it wanes. Moderna, we're still waiting to see the data, but it'll be similar, around 6 to 7 months. And the Johnson vaccine, which has been used a lot in the US, it wanes as well. And that's why they're recommending a second shot for the Johnson vaccine. What will immunity passport get you? Well, growingly in every province, gets you into a bar, a restaurant. You get to see the Leafs games. I don't know about the Blue Jays. They probably have to be vaccinated to get into a Blue Jays game. Growingly, this is going to be a national passport program. If you want to go do stuff, you're going to have a passport. What about long-term adverse effects? I can tell you as of today, almost 6 billion people have received COVID. So we know everything about these vaccines, and the benefit of them unbelievably outweighs the risk. Is COVID-19 here to stay like the flu? I think the answer is yes. It's not going away, as you saw. Now, what about these variants? You hear 2 different terms, VOCs, variants of concern, and the other one is VOIs, variants of interest. Interest is we're watching them to see what happens. Concern means they're spreading around the world and causing disease. The big one these days, everyone's talking about Delta. Why? Delta is more likely to make you sick, more likely to spread, more likely to kill people, and the vaccines are slightly less effective. What are the unanswered questions? Are they more transmissible? Yes. Do they cause more severe illness? Yes. Can we detect them through diagnostics? Yes. Remember, PCR detects the virus, the viral RNA, which is conserved. Do the drugs work? We have to see if they all work against the different variants. But so far, the answer is yes. And the vaccines in general are a little less effective against Delta. So I want to show you this slide because growingly you hear people on TV saying, you know what? I'm not going to get the COVID vaccine. Why? I hear people are getting infected even though they're vaccinated. The vaccines are not designed to prevent getting COVID. Yes, they're good at preventing it, but they're not foolproof. What they're amazing at is preventing death, ICU, ventilation, hospital admission. If I go to Ontario now, I know for a fact as of tonight, everyone in the ICU in Winnipeg or Manitoba, everyone in the ICU in Alberta is unvaccinated. And it would shock me if it isn't the identical situation in Ontario. The people who get really, really sick and die are virtually all unvaccinated. And that's the key. That's what the vaccines do, is prevent serious illness and death. So is COVID-19 here to stay? I think so. You know, you got a bunch of respiratory viruses here. And I think this is going to be there, just like adeno, rhino, influenza, RSV. This is going to be here for a while. It's not going to leave us. I'm going to finish up with 2 minutes of vaccine hesitancy, and I have my last polling question. In your practice, are you seeing vaccine hesitancy in your patients, whether it's COVID vaccines, the flu shot, pneumococcal vaccines? Are you seeing hesitancy? Are people hesitating and talking to you about it? What are they saying, Ruth?
They are seeing a lot of it.
Wow.
We got 94% of people are seeing it.
Wow. Well, this is fantastic to hear from you. Thank you for sharing your knowledge. So let's talk a little bit about this. This is a complicated issue. So it turns out this is more complicated than we thought. And the World Health Organization convened a bunch of experts and said, look, we think this is a combination of confidence, complacency, and convenience. And you got to kind of sort out where your patient is. Is the delay in acceptance or refusal, is it due to, well, you know, I just don't feel like it. I'll wait to see what happens with other people. Is it, well, you know, it's not really convenient for me. No one's coming right to my house to give me a shot, so that's not convenient. Or are they worried about adverse effects? What are they worried about? So in Ontario, and this is kind of cool, a group of pharmacists have put together what's called a CARD program. And this is for improving vaccination in general, not just COVID, but it was put together because of COVID, but with other vaccines. The first C is comfort. Maybe you ask your patients, do you want to put on short sleeves so you don't get any blood on your shirt? Would you like a little snack just to make them comfortable? The A is ask. Would you like some numbing cream? Do you want to look or not look at the needle? How can I make you feel better? R is relaxing. Do you want to bring a friend? Do you want complete privacy? How would you like to go about this? I just want you relaxed. And last is distraction. Do you need distraction? Maybe you're talking to someone while I'm giving you a vaccine. Maybe you're playing with your phone. Maybe you're looking at a picture. This is very cool, very simple, something we can remember. CARD, comfort, ask, relax, and distract. From a healthcare professional, the most important that's been found is we can't be the negative ones. When you have a pharmacist who's spreading misinformation that the vaccines don't work, they're impregnating Bill Gates chips into your brain or something like that, it's devastating when it comes out of a pharmacist's mouth, a nurse's mouth, or a doctor's mouth. Patients. What you're doing with your patients is you are listening. You're listening more than talking, and you're trying to ask questions, listen to find out what is their hesitancy? Are they worried about pain? Is it a convenience issue? I don't have time. Are they worried about adverse effects? Do they think you're going to implant the Bill Gates chip? What are they worried about? And then you, as a trusted professional, are trying to comfort them and give them evidence-based information that doesn't come from Facebook or Snapchat. Ruth, I'm going to stop there. You know, the highlight of all this is hearing from you. Questions, comments. I'm happy to go back to my pneumococcal cases and vary Carol's age, or vary the situation with Doug or with Florence. I'm happy to hear about any of your experiences or questions. Ruth, is anyone awake out there, and did they ask anything?
Yes, we got some questions. The first one is a really good one. Can you give Pneumovax 1 to 3 years after Prevnar if it was missed?
That's a great question. The answer is yes. So if you gave, was it Prevnar or Pneumovax? What was the first one? Can you give which one?
Can you give Pneumovax?
Yes, good. So the ideal situation in any of your patients, and you have to remember this, is you give the conjugated Prevnar 13 first. Why? This is the fancy technology. This is the sugar and the protein joined together. You have a glycoprotein. You get a T cell, B cell immune response. After 8 weeks, anytime after, you've had a maximal immune response. Anytime later, 8 weeks later, 3 months later, a year later, 3 years later, whenever you remember, you give Pneumovax. Absolutely. The key is not shorter than 8 weeks, but anytime after that. Yes. Excellent.
So let's go back to the flu vaccine just for a moment. What will the flu vaccine this year be based on?
Great question. So what we do is we look at Australia. We, being in the Northern Hemisphere, we look at the Southern Hemisphere. So we're going to look at places like Australia and New Zealand. And so far, they have had a reasonably mild flu year. But don't forget what's happened is COVID exploded in Australia in the past while during their flu season. So they've had lockdowns. Before that, as you know, Australia and New Zealand had a very interesting plan. They just stopped allowing anyone onto the islands. And if you did come, they escorted you to hotels to do your quarantine. And they were amazingly effective at preventing the spread of COVID. But then Delta came in. And it has gone nuts because they're not vaccinated. Australians were not vaccinated. So it has gone nuts, and they've shut down the country during the flu season. So they've had lots of masks, lots of shutdowns, but they had a relatively mild flu season. But what we do is we look at the virus that's circulating in Australia and New Zealand. And then what we do is we formulate the vaccine based on what we've seen. And what we've seen, we're going to have 2 A's and 2 B's, and virtually all the vaccines will be quadrivalent. But it'll be what are the most circulating strains, common ones, in the Southern Hemisphere. And that's what we bring. And we kind of hope. And what happens in a good year, we have about a 40% match. If we get super lucky at 60, 65, sometimes it's as low as 20%. But it's based on what is circulating. And then you're going to ask me why. A colleague of mine, Dr. Greg Hammond, here at in medical school, has been working with the wind experts in the world. And it turns out that all these wind currents that occur around the globe, that one of the important things that they move around are pathogens, and especially viruses. Believe it or not, viruses are not just carried by people and birds. We always thought it was always people or maybe migrating birds. Viruses actually go through these national, international wind currents. And the viruses will come here via wind currents as well. And they typically will come from the Southern Hemisphere. So that's what we do. We look to see what they have, and that's what we stick in the vaccines, and we kind of hope. Great question.
Yes. So let's go back to the COVID vaccines. So you talked about the immune response decreasing after 6 months. Is it a cliff? Is it a gradual?
It's gradual. So it is not a cliff, it's gradual. And again, realize I'm generalizing. So I'm lumping in a healthy 40-year-old who was immunized with someone who's 85 years old with medical problems, someone who's 30 and I'm lumping them all together. Generally speaking, as you know, if the older you are, the less of an immune response you have with your 2 shots, and they really need more boosting. They appear to wane faster as well. If you're relatively young with no medical problems, your 2 shots gives you a huge immune response. You wane slower. If you're immunocompromised, many of these individuals will have a lower immune response in general. They really need the 3rd booster, and they seem to wane a little faster. So it is not a cliff, but it really depends on the individual patient. I'm generalizing to tell you that for Pfizer, we know you're very good for 6 months, and then we start to wane. How quickly we wane will depend on that particular individual. And the data we've seen from Israel is if you boost someone who's older, immunocompromised, or younger, the immune response is amazing. The booster really works.
Okay, so we're popping back to pneumococcal.
Yes.
So you have a patient, they're 80 years old, and they can't remember whether they got Prevnar or not.
Yes.
So what are you going to do? Can you give it again?
Great question. So you have Florence, and she's 80. She comes into your practice and says, my daughter said I should get the pneumonia shot. And you say to Florence, have you received any kind of vaccine shot in the last year? She says, I don't think so. You're good to go. So if it's me, at that point, I'm going to give her a flu shot. First of all, HighDose Flu, right? Because you got to do that annually anyway. I'm going to do HighDose Flu in this arm, and it's free and recommended. And I'm going to give her Prevnar 13 in the other arm. And then 8 weeks later, I'm going to invite her back, and I'm going to say, Florence, I want you to come back, and I'm going to give her Pneumococcus. And then she's good. How long is she good? At least 5 years. I don't know what we do after when Florence turns 85 or even 90. But what I do want you to remember is if you decide that you're going to boost, so let's say Florence is 65, and you give her Prevnar 13, 8 weeks later, Pneumococcus. And then 5 years later, Florence comes back and says, what are you going to do for me now? We have no data on that. But what I want you to remember is if you ever do boost her at the age of 70 or 75, you always give the conjugated first. If it's me, if it's Florence, and she's 65, I give her Prevnar 13 today, 8 weeks later, Pneumococcus. She comes back at the age of 70, she's healthy, she's active, she wants maximum protection. I'm going to give her Prevnar 13 again. And 8 weeks later, Pneumococcus, because the benefit is dramatically going to outweigh the risk. There is no risk. These are unbelievably safe vaccines. And especially if she's had them before, they're safe. I will say, Ruth, and this is kind of, giving you some of my skeletons, we accidentally, in one patient in Winnipeg, we gave them Pneumococcus 3 years in a row, thinking it was the flu shot. And I apologize, and I'm not saying this is general healthcare over here in Winnipeg. This was an accident. But why I'm telling you this, it's safe. Even if you overdo it, it's safe. These are very, very safe vaccines. So if you don't know, you ask a question. Have you received any kind of immunization in the last year? If the answer is no, you're golden. Prevnar 13, 8 weeks later, Pneumococcus. Really great question. Thank you.
So now we have a tough case here. So 35-year-old in your pharmacy, obese, they have asthma. So you recommend Prevnar 13 and Pneumococcus.
Great question. So
when is the next shot? At
great.
40?
So I've got I'm going to turn Doug into this patient. I'm 30 or 35?
He's 35.
35, diabetes, obesity, correct?
Yep, and asthma.
And asthma. What are you going to do? They've got to get a flu shot, right? They got to get the regular quadrivalent flu shot that's going to be in Ontario this fall. That's in one arm. In the other arm, to me, risk versus benefit. Minimally, they get Pneumovax as per the guidelines. So minimally, they get the flu shot here and Pneumovax here. Those are the guidelines. But then I think what you're doing is you're saying to yourself, risk versus benefit. I've got a 30-year-old, I've got asthma, huge risk factor for pneumococcal pneumonia. Obesity, risk factor for pneumococcal pneumonia. What else did I have? I had something else.
Asthma.
Asthma and diabetes. Diabetes, huge risk factor. So let me go back here and just go over with this question, the risk factors. Sorry about this. Please don't have a seizure on me here. Sorry about this. I'm very sorry. And I'm even more sorry because I lost it here. Let me go 25, enter. Oh, I'm getting closer.
So while you're doing that, I'm going to answer another question that you'll get a recording of this session as well as the slides after the presentation in a follow-up email. And if I'm really fast, you'll get it within 24 hours. If I'm not so fast, it's 48 hours.
Thank you, Ruth. I want you to look at this slide. Your 30-year-old has diabetes. You see diabetes here on the left, huge risk factor. The patient was also obese. I don't think I have obesity here, but we do know that obesity is a risk factor for all types of pneumonia, including pneumococcal pneumonia. But then look at asthma. Asthma and lung pathology is an enormous risk factor. So at this point, you say, well, the guidelines don't recommend Prevnar. The guidelines recommend a flu shot and they recommend a Pneumovax. But if you're asking me, does the benefit of giving Prevnar and then Pneumovax outweigh the risk in this patient? 30-year-old, diabetes, asthma, obese? Yes. I just don't have yet a study to prove that to you. Those studies are underway, and I will have that. As you know, I showed you the study of 50 and older with a medical problem, and that suggests we should give Prevnar and Pneumovax. For your 30-year-old, evidence-based is flu shot and Pneumovax. If you're asking me, I think the benefit of giving both Prevnar and Pneumovax would outweigh the risk. And I think it's worthy asking your patient that and recommending both Prevnar and Pneumovax. But in terms of evidence-based, Prevnar is not there yet because we haven't published a paper on that yet. Thank you, Ruth.
So you're really kind of stimulating some questions here. They want to pick your brain on everything. So here's another one. And I can just see this. So some patients, no comorbidities, healthy individuals, they're in their 50s and they're insisting, I want my Prevnar shot. Give it to me.
This is a great question. I will tell you that there is data now from Canada. I showed you the LeBlanc paper, 50 and older with a comorbid illness. Huge benefit to give them both Prevnar and Pneumovax. If you are asking me risk versus benefit, I want you to remember this. We give children vaccines to get them off to a healthy start. That's what we do. Mumps, measles, rubella, invasive Haemophilus influenza. We give the kids the vaccines to get them off to a good start. We have realized over the last few years, we give adults vaccines to keep them healthy. That's what you're doing. And if you've got a 50-year-old who wants to stay healthy and they're willing to pay, does the benefit of getting Prevnar and then Pneumovax outweigh the risk? Absolutely. To me, I would if they want it, I would recommend it and give it to them. Why? It's unbelievably safe. And look at age. I'm over here, 50 to 60 years of age, where my arrow is. Age doubles your risk factor for pneumococcal pneumonia. So I think it's a good idea.
Yeah, it
Keep
sounds
them
like it.
healthy.
Yeah, they're trying to stay safe. And here's another question. We're back on COVID, but I really want to know the answer to this. What if you gave a COVID shot to someone who was actively COVID-19 positive?
Great question. So in the September 28 document, I try to distill this 148 pages into one slide for you, but it's very clear in the document that says if someone has active COVID illness and they have symptoms, we want you to wait for about 2 weeks after they are asymptomatic. So if someone's acutely ill with whatever, an asthma exacerbation, they're hospitalized with a GI bleed, they've got COVID, active COVID disease symptoms, we want you to wait, ideally for a couple weeks after their acute illness has subsided, including COVID, then you give them the shot. And what we do know then is if you've actually had the illness, if you've had COVID, the disease, and then you get the shot, unbelievable immune response. That's probably the best immunity, is be an idiot, don't get vaccinated, get COVID, don't die, then get the shot. You're gonna have the best immunity possible. Ruth, I'm not advocating not getting the COVID vaccine, getting the disease and then the shot. But if you do get sick, we wait till you're over your acute illness and then we vaccinate and you'll get really good immunity.
Fantastic. Okay, this is the last one. This is the big one that many people, you could go on television and answer this question. So at what point is the pandemic declared over, even if COVID's still here?
So I do not, this is a great question, and it doesn't have an answer, so I'm going to tell you what I think. I don't think anyone's going to declare the pandemic over. This is not going to be like SARS-1 in Toronto in 2003. This is not going to be like MERS, the Middle Eastern equine virus that was in Saudi Arabia and the camels. It's not going to go away. I think what's going to happen is people will start to use the term endemic. So pandemic really means that we're affecting the whole globe. Things are out of control, morbidity, mortality. But once we get to a situation in Canada where we have some sort of baseline level of infection that doesn't really go away, doesn't go up very much, doesn't go down, it kind of just, it's here forever. It's not overwhelming the hospital system, not overwhelming our society, but it's there. And we just know that in Canada, we have 900 cases a day and 2 people died every day. It'll get what's called endemic status, and it'll be here probably forever. So I don't think we're going to say the pandemic is over, but theoretically, the pandemic would be over once all the countries started seeing the cases plummet down to virtually nothing.
Yes.
And we started to get back to normal, and we didn't see massive waves of infection. Theoretically, that's when you call it over. I don't think anyone is ever going to use that term. I think they're going to use the word, you know what, we're now at an endemic level, and we'll tolerate that amount of infection and illness and death and get on with our lives. I think that's because Alberta was trying that term, if you recall, in the summer, and they got burned.
Yes. Yes.
Right? Delta came in, and Delta said, whoa, poor vaccination, no masks, lots of freedom. Love it. And now it's going crazy.
Someone asked if we're going to wear masks forever. And as far as I'm concerned, I haven't had a cold or a runny nose for a very long time.
You know, masks are a funny thing, Ruth, because many people hate them. Some people tolerate them. Some people like it. I don't have a problem going into Sobeys or wherever to get groceries and having a mask, even if COVID is gone or endemic, for the same reasons you're saying. You know, if you're in these settings, especially in the middle of flu season, rhinovirus, adenovirus, all these other things, there's a benefit of people not sneezing on you all the time. So I think some people will have masks now forever.
And if you're sick, wear a mask, no matter what. Let's make that part of our culture.
Ruth, I have to tell you that I was born in Eastern Europe. I'm a Czechoslovakian guy. And I was fortunate enough to immigrate to the greatest country in the world when my parents came here when I was 6. I was raised by Eastern European parents. If you're sick, you go to work. You want to show the boss how tough you are. That's the stupidest idea I've ever heard. I go to work, I'm sneezing, I'm coughing, I'm spreading my viruses to everyone. I'm not showing everyone I'm tough. I'm showing them I'm an absolute idiot from Eastern Europe. Don't go to work and school if you're sick. Absolutely.
Exactly. Well, this has been absolutely fantastic. You're a great speaker, very engaging, and I enjoyed it a lot. We got lots of questions, so and I like the idea of trying the cases a different way. So I really appreciated it. To everybody, remember, you're going to get the recording and the slides, and we have a great rest of the evening, and let's hope to this week and this day makes a change for Canada as far as the Truth and Reconciliation. So thank you everybody for coming, and again, have a great evening. Goodbye.